Acute glomerulonephritis is a disease characterized by damage to the glomerular filtration apparatus, and this causes protein and blood to leak into the urine. So, mechanisms for the glomerular damage may be immune mediated, and this condition may be associated with hypertension and fluid retention. The main causes are post-streptococcal infections, could be pharyngeal or skin infections, also infected scabies and other bacterial infections, for example salmonella, and also hepatitis B virus, hepatitis C virus, HIV. It could be from parasitic causes like malaria and schistosoma, and also systemic lupus erythematosus and other vasculitis. So the symptoms are history of preceding infection, generalized edema, most marked around the eyes, breathlessness, anorexia, sometimes associated with vomiting and abdominal pain, fever, seizures, scanty urine, and hematuria. And the signs that are usually elicited are edema, oliguria, that's urine volume less than 400 milliliters per day, and also hypertension, hematuria, dark colored urine, acute heart failure, and coma. Investigations, urinalysis, sediment shows erythrocytes, leukocytes, and a variety of casts, including erythrocyte casts, and proteinuria, usually less than 2 grams per 24 hours, but may be in the nephrotic range. Also FBCB creatinine, throat cultures in children, and this may be very useful in children. And chest x-ray may show pulmonary edema, ECG, immunology, for example NA, anti-dsDNA, and also ASO, that's anti-streptolysin O titers, and ultrasound of kidneys. So the main treatment objectives are to identify and stop the cause of renal injury and to prevent and control complications. Non-pharmacological treatment, bed rest, salt restriction in diet, and control fluid balance. So adults control fluid retention by restricting daily fluid intake to 800 milliliters plus previous day's urine output. And children, you restrict fluids to 400 milliliters per meter square of body surface area and previous day's urine output. Pharmacological treatment for fluid retention in post-infectious glomerulonephritis, if furosemide oral or IV in adults 40 milligrams daily and increasing to 80 milligrams daily. In children 1 month to 12 years, if 1 to 2 milligrams per kilogram per day initially, and increase by 1 to 2 milligrams per kilogram 8 hourly to a maximum of 6 milligrams per kilogram per day, not to exceed 80 milligrams per day. Neonates 0.5 to 1 milligram per kilogram 8 to 24 hourly with a maximum of 2 milligrams per kilogram. For hypertension in post-infectious glomerulonephritis, you treat the blood pressure appropriately. So refer all patients with complications of renal failure, severe cardiac failure, and hypertensive encephalopathy that arise following post-infectious glomerulonephritis to a physician specialist or a nephrologist. And also patients with other causes such as lupus nephritis or systemic vasculitis should also be referred to a physician specialist or a nephrologist.